In our previous session, we did discuss about the phenotypes and endotypes of asthma. What is this T2 high and T2 low asthmas? Let's look into that. I'm Dr. Manjunath, a pediatrician and allergy specialist based in Bangalore. Well, as we all have understood by now, that asthma is a very heterogeneous disease, and the complexity of this disease was understood way back in 1940s and 1950s. There has been a lot of evolution in understanding of the disease to its present day as on today. If you look at the types of inflammation, there are basically three types of inflammation which are very important in asthma. One is type 1, where interferon gamma and TNF alpha are the more important chemokines which are in the inflammation. These basically evolved to target the intracellular microbes. And then the type 2 asthma, that's more important for us, where the interleukin 4, interleukin 5, interleukin 13 are very important. These evolved for the protection of from the parasites and to tackle the allergens. This is where it gets interesting. Okay. And there's another type, that is the type 3 inflammation, and that is where it is mediated by the interleukin 17, which is evolved to tackle the extracellular bacteria and fungi. Unfortunately, all three types of inflammation are seen in asthma phenotypes. This results in its heterogeneity and affect the composition of its granulocytic activity, leading to inflammatory phenotypes which can be either eosinophilic, neutrophilic, paucigranulocytic, and a mixed pattern can also be seen in our airways. Well, in asthma, we can have T2 high asthmas or T2 low asthmas, because that's one thing which we mostly see in our day-to-day basis. It is meant to tackle, as we all understood by now, that it is meant to tackle the parasites and allergens. Eosinophilic airway and the infiltration is mostly Th2 dependent, and that's the reason, and that is why it is called as T2 high asthmas, which results in the overexpression of interleukin 4, interleukin 5, and interleukin 13. Interleukin 5 is needed for differentiation, activation, and survival of the eosinophils. Whereas interleukin 4 and interleukin 13 induces the B cells and resulting in the IgE formation. T2 high asthmas can again be divided into allergic and the non-allergic phenotypes. T2 high allergic variants are the archetypal things what are seen in our pediatric age groups. That is early onset, there is raised specific IgE, history of atopy, skin prick test being positive, and typically these ones are steroid responsive and they are likely to have remission at a longer run. These are the typical ones what we see in our pediatric age group, and we are fortunate because these are likely to go for remission. And again is T2 high or the non-allergic one. These result from the non-specific mechanisms. It can be either pollutants, parasites, and pathogens. These ones are alarmin mediated ones, and the leading to innate lymphocyte 2 activation. How do they present clinically after having understood what is the pathophysiology? How does it matter to me? How do we see it on a clinical basis? It is simple. We see typically these ones are the late onset ones, the female ones, They can be associated with rhinitis, chronic rhinosinusitis with polyps. And this polyposis can precede the development of asthma. Okay. And then we'll come to T2 low asthmas. Okay. One thing is aspirin exacerbated respiratory disorders also come to T2 high asthmas. Okay, that's another thing. And let's come to the T2 low asthmas. Uh, on an average, in one study, uh, about 19.5% of all asthmas are T2 low asthmas. How do they present clinically? Clinically, they are older patient, late onset asthmas, mostly have a smoking history, they have higher body mass index, they can also have less, rather they don't have the rhinitis as a problem or chronic rhinosinusitis as a problem. They are typically likely to have arterial hypertension, may also have history of myocardial infarction and gastroesophageal reflux disease. And obstructive sleep apnea syndromes can also be seen in these patients. The typical profile of these patients are older, overweight, and they can also have peripheral neutrophilia as a combination. In T2 low asthmas, we can also have obesity related asthmas, and the very late onset of asthmas are T2 low asthmas. These are typically non eosinophilic asthmas, and they are steroid resistant asthmas. These are the characteristic of these T2 low asthmas. But fortunately, the severity of these asthmas are much lesser in comparison to those of T2 high asthmas. And that is a good thing for us. If ever you are handling these adult type of asthmas where they're very late to present, they have chronic niggles, that is understood. But fortunately, these ones are not very severe in their clinical manifestation. Well, having understood the different types of pathophysiologies, do we really see all of that and can we really make a differentiation in our clinical practice? The answer is yes. We'll be able to, if you have understood gone through the entire T2 high, T2 low, and how do they present, it's not very difficult to understand what sort of phenotype and endotype any patient is coming through. It's that simple, rather easy. But it's not plain and simple. There are some gray areas because these T2 low asthmas can also have some obscure, rather unknown pathophysiological and immunological manifestations which are yet to be understood. There are alarmins. These alarmins are the thymic stromal lymphocyte protein, interleukin 25, and interleukin 33. These are the alarmins. They in turn stimulate your immune system to produce different types of mechanisms. For those interested audience, this is an image which shows the T2 high, T2 low asthmas, possible biomarkers, possible chemokines, and the biologicals which are used to treat all of them. Pause it, see it in detail, and I have also put the reference where you can get this image. There's another type of inflammation, that is type 3 inflammation, which is also being reported more and more in these days. These are typically mediated by the innate lymphocyte 3. These produce the interleukin 17 and hence the manifestations. These are typically involved in the asthma exacerbations. The understanding is yet to evolve. There's a lot of theories proposed. The clinical manifestations and the associations are evolving, and probably we'll have more and more understanding in due course of time. With this, I have touched upon the T2 high asthmas, T2 low asthmas, and type 3 asthmas. if you have stayed this far, please like, subscribe, and share this video among your friends. I'll try and bring out more and more videos related to asthma and allergy. Thank you.